Hello, everyone. Thank you for joining us today. My name is Lauren Steffes, and I am the marketing specialist at OSMS. Tonight, we have Dr. Peter Eggert here to talk about rotator cuff injuries and then discuss some treatment options for those injuries. Dr. Eggert?
All right. Thank you, Lauren, and thank you, everybody, for joining tonight. My name is Peter Eggert. I'm an orthopedic surgeon here at OSMS. Just a brief history about who I am, kind of the things I take care of, and then we'll do a brief talk on rotator cuff injuries. Part of this talk is going to be some questions and answers at the end, but I hope I can give you quite a bit of information about rotator cuff injuries, treatment options, answer a lot of questions that maybe you're thinking about. And if you have anything that you want to ask, please feel free to. Brief history about who I am. So I went to medical school at Creighton University. I did my residency in Milwaukee at Medical College of Wisconsin. And then after a residency, I did an extra year fellowship, so one extra year of training in sports medicine at the University of Wisconsin-Madison. There were a couple of my mentors that were part of the football teams. We did a lot of work with the UW Badger football team, a lot of sports medicine, non-operative care as well as operative care. So my expertise, I do a lot of general orthopedics, but also I focus on sports medicine as well. So general could be anything from fracture care to joint replacement. But I really like the sports medicine, and that encompasses a lot. There's a lot that goes into that. So my kind of focus in sports medicine, I really like shoulder work, knee work. So in the shoulder, rotator cuff injuries, labral injuries, and so that's why I thought tonight let's talk about rotator cuff injuries. So the rotator cuff, I think, is interesting because this encompasses a lot of different rotator cuff injuries can happen at any age. I think there's a lot of injury patterns that occur. So I think it's really unique. I don't think there's just one specific injury and that defines a rotator cuff. So, but first of all, what is the rotator cuff? So first of all, this picture, hopefully you guys can see the arrow. Your shoulder is made up of this ball and socket joint. And so the ball isn't real round, the socket is really shallow. So one main structure to keep this ball centered in the socket is this group of four muscles that basically wrap around the head to keep it centered. So that's your rotator cuff. So it's made up of your supraspinatus, infraspinatus, subscapularis, and your teres minor. That's just the names of the muscles that make up your rotator cuff. So two tendons are on the top. You have one in the front called your subscapularis, and then one in the way back, which we don't see, is your teres minor. So these are really important to keep that ball well centered as you bring your arm through range of motion. That keeps the ball centered, and then your deltoid does a lot of power to power the shoulder. So, all right, so I'm going to kind of talk, my presentation is going to be basically almost like how I see patients in clinic. And I think this will make sense for this talk. So patients often come in, they can have pain that may be sudden. So if they had a fall, they slipped, either fell on their arm or they're falling and grabbed onto something to brace them, they can have this sudden acute pain, or they can often have pain that's been going on for months or years. Typically, most patients complain of pain somewhere in that lateral or the outside part of their arm, kind of over the deltoid region. The pain may radiate up into their neck or may radiate down to their elbow, sometimes all the way down to their hand. Which is very common. A lot of patients have pain at night, difficulty sleeping on that side. Sometimes that's their only complaint. So during the day, they're fine, everything's great, but they can't get comfortable at night, or it wakes them up from sleep. Some patients come in complaining of weakness, especially if you have this a bigger tear. We'll talk about that too, where you've torn the tendons and you can't really power the shoulder, so you can definitely have some weakness. A lot of patients will have decreased range of motion. This can be either from weakness. They just can't really raise their arm very well, either in front of them or out to the side or even rotating. Could be from tendon injury where the tendons aren't attached, or related to pain that they limit how much they want to use this arm because it hurts. So when patients come in, we talk about their presentation, their symptoms, how long things have been going on, where do they get pain in their shoulder, and then we do an exam. So on an exam, most often patients are going to have limited range of motion, again, either due to pain or weakness. Often I bring through patients through range of motion. So what you're going back to what your rotator cuff functions to do and kind of the anatomy, you have those 4 groups of muscles. Above, which I didn't show, above the rotator cuff, you have this bone called your clavicle or your collarbone, as well as your acromion. So as you're rotating your arm, you can pinch your rotator cuff tendon seen here, the top 2, your supraspinatus, your infraspinatus, on the bone above called your acromion. So there's a diagram here. So patients can often have, as they start to raise their arm out to the side, it's pretty comfortable and no pain. And then they get into this area where, it's really quite painful because you're impinging that rotator cuff tendon on the bone above it. And then at some point we get past it because your rotator cuff tendon has now rotated way into here and it's no longer being pinched. So often patients have pain. We talk about at or above shoulder height level is where most patients feel most of that pain when they have a rotator cuff injury. So that's one of them. So we go through range of motion. So in different planes, we bring their shoulders through range of motion, both actively and passively, which is me moving their arm. And then we do some strength testing. So there's a lot of different exam maneuvers that we might do, but the big one is testing your strength. And so with these diagrams, we're just showing you how we isolate the muscles. So this is to test your supraspinatus. We bring your arm out, kind of out to about that shoulder height level, rotate your arm down to really isolate that muscle and tendon group. And then we're pushing on it as you're pushing against us. Same thing with external rotation. We're trying to see how strong you are rotating that arm. If you have any weakness or pain, that clues us in on specific muscle groups. Also, impingement, we're looking for any sort of irritation as we rotate that arm back and forth. We are rotating that rotator cuff back and forth and trying to irritate it up against that acromion or that bone above. So once we do the exam, we get x-rays. We often start with x-rays. They can pick up some good information, but now they don't show us all the soft tissue structures. So shoulders, again, is made up of this ball and socket. And then you have your collarbone coming over the top. This is that bone on top called the acromion, which then that wraps around the back and attaches to your shoulder blade. So on x-rays, we're making sure you've got good space between the ball and socket. If you have any narrowing, that's the process of arthritis. You're losing your cartilage and that space narrows. Your rotator cuff, again, we don't see on the x-rays, but 2 of those tendons and muscles run right through this space and attach out to this landing zone, or we call it the footprint. And then you have a rotator cuff tendon in the front and one in the back. So want to make sure everything looks fine on the x-rays, good space, no fracture, because that's another thing that we can see when patients injure their shoulder. So once we get the x-rays and I've examined them, I've talked to them, I'm already thinking in my mind, okay, what could this be? And when I think rotator cuff, that can be a lot of different things though. So you can have tendonitis, you can have a partial tear, you can have a full thickness tear. So this is just a little schematic or image of, here's your rotator cuff tendon. This is the top tendon here. They're showing your supraspinatus, and there's a tear through there. So you can definitely tear the tendon either acutely. So if you fall, like we talked about before, you can fall and you can tear the tendon or rupture your tendon. There's different sizes of tears that gets pretty specific and probably beyond the scope of this practice or this talk. You can have partial tears, or the tendon can just be really inflamed and irritated, and we can see that on MRI. So different treatment for all of these, and there's also some treatment that kind of same treatment for all of them as well, and I'll explain that here shortly. So once I get the x-rays and I talk to patients, with my exam findings and say, yeah, my differential, I think we've injured the rotator cuff, could be tendonitis, might be a partial tear, or I'm really concerned that you have a full thickness tear. Often getting an MRI is a very common thing we do to really look at that tendon. So MRIs are going to show us all the soft tissue structures as well as the bony structures. So this is just what an MRI looks like. They can be pretty confusing. I like to scroll through the MRIs with patients in clinic because I think the anatomy for trying to describe the anatomy around the shoulder can be pretty confusing. We're now looking at pictures. So I bring patients back once we get the MRI and run through everything. So this is looking at your shoulder from a straight on view, just like that x-ray. MRI, we can scroll through front to back, sideways, top down. So this front to back view, this is your supraspinatus, this oblong structure, that's the muscle. Then tendon forms within the muscle belly, and it attaches to that little flat area that we saw in the x-ray. So this is good looking tendon. So it should be nice, solid black. Sometimes there's a little gray in it, but most of it's nice and black. There's two images here on the right. This is looking at, again, this shoulder from a straight on view. This is the ball and this is the socket. That tendon that we were looking at before comes over the top, and then here it is, and then it stops. There's this white gap here. That's a full thickness tear of the rotator cuff tendon, of your supraspinatus. So we don't want to see that. Oops. So that's a full thickness tear. Down here, you can have a partial tear. So this is the tendon coming over the top, and you've got some that's still here, but then some that is torn. So you can have some, that's what a partial tear looks like versus a full tear, this big gap. So treatment options. So whether you have some tendonitis or even a partial tear, there's some non-operative options, even some full thickness tears. I've got some patients that we might try some non-operative things. Again, with rotator cuff tendon tears, I don't think there's one treatment algorithm that's for everybody, that fits everybody. I think that's why I like rotator cuff injuries, because it's very unique to each person and there's a lot to talk about, and we can kind of try different treatment options, and we'll start in one place, and if it doesn't work, okay, let's move on to the next thing. So non-operative things can be anything from simple rest. Hey, the rotator cuff tendon is irritated, it's inflamed, we got to rest it, let things kind of settle down. Or if you have a little partial tear and it's not a real big tear, we can try to let things kind of calm down and see if we can get your pain under control. Modifying activity. The big thing is avoiding overhead activity. So again, going back to that diagram or that picture of that patient moving their arm through that painful arc, if we can get this impingement or pinching as we raise the arm. So we're going to try to avoid doing a lot of work out here on the side, or even like lifting heavy weights out to the side. Anything, if you are going to work your shoulder out to the side, real lightweight or very limited weight. Anti-inflammatories. So there's a whole bunch of different anti-inflammatories, anything like ibuprofen, Aleve, you can purchase over the counter. There's prescription anti-inflammatories we send in. I've got some patients that try to do more natural anti-inflammatory options as well. Ice, heat, you can do both. I have a lot of patients ask which one's better, ice or heat. My simple answer is, if it feels inflamed, swollen, ice. But at the end of the day, honestly, whatever makes it feel better. Everyone's a little different what they like with those. Physical therapy is a great option. So tendonitis, partial tears where the tendon is still pretty much intact, we can still try to do some physical therapy to strengthen the rest of the rotator cuff musculature and the deltoid, all the other muscles around the shoulder. There's a lot of other muscles that attach actually to the shoulder blade that we want to work on as well. So physical therapy is a great place that we also start with. It's non-operative. And then injections. So injections, there's a few different options. Most commonly, you're talking about like a steroid injection with a lot of patients. Steroid injection it's not an anti-inflammatory, but it helps decrease the inflammation, knocks down the pain so that we can get you moving again. Now, there's been a lot more research into some of the biologics. So that can be PRP, which is platelet-rich plasma, which is the platelets are derived. So it's a component of our own blood that we do a blood draw from the patient, spin the components, so you separate out the components, and then you get the platelets and you inject that into the tendon region. So that's an option. Collagen injections is a kind of a newer thing as well that's being studied. So there's some other options besides just steroid. So non-operative options are good for patients that they've been having pain for some time. It's kind of this gradual onset. It's been getting a little bit worse and worse. I think you can definitely do some non-operative things, see if we can calm it down. If I have patients that come in and they fall and they can't move their arm, and we get an MRI and they got this full thickness tear, those are ones that I say, yeah, I'm not sure if we should wait on non-operative or try non-operative. I think we need to fix this because we got to repair that tendon. It's completely pulled off the bone. So, but there are some tears that are all the way full thickness through, but they're really small. I've got some patients that, they want to try some non-operative things first and see if we inject it, see if we can get the pain under control, do some physical therapy. And I'm happy to try it. You can repeat cortisone injections. A lot of patients will ask about that. How often can you repeat them? I think it's reasonable to repeat, an injection once or twice, kind of depending on the time frame too. If you get an injection, you come back, a couple weeks, or a couple months later, and it's still a little sore, you can repeat it. But if you're doing it every 2 months, 3 months, that's a concern because that can weaken the tendon. So if we decide, hey, we got to move on to surgery, the chance of getting a good repair is less because we've done a bunch of cortisone shots into that tendon. It can actually weaken the tendon. Um, so if non-operative options, either after the conversations, hey, let's go on or let's not, spend our time with non-operative things. We really got to get in there and repair that tendon. Or if non-operative things have failed, and we say, hey, we're still in some pain, there's definitely operative options. And so from an operation standpoint, there's really two kind of main options. So they're both arthroscopic. So I do arthroscopic surgery. Kind of traditionally, a lot of patients would get an open procedure to address rotator cuff issues. But in my training, and a lot of more commonly nowadays, we're often doing arthroscopic. So arthroscopic basically means using smaller incisions, putting a camera into the shoulder, looking through the camera or looking through a video screen, and then working through multiple poke hole incisions and doing all of our work using instrumentation that's kind of longer, but we can kind of grasp and tie and things like that all arthroscopically. So you can either debride the rotator cuff tendon. So this is for partial tears that are not real thick in kind of extension. So we break the tendon into kind of 50%. If it's less than 50%, we can try to debride the tendon. Because sometimes it's just really kind of beat up tissue and gets irritated. So he's got to smooth it out, debride it. Or else if you do have a large partial tear that's beyond 50% or a full thickness tear, I'm going to go in there and actually repair it. So this is essentially what arthroscopic rotator cuff repair would look like if you're in the OR and you see the patient, or if you got to kind of see what we see. So all the blue, we call it the drapes that are basically draping out the majority of the patient. So after we get the patient to sleep, we get them positioned, and then we clean up the skin using some different kind of cleaning solutions. Then we drape out the patient's extremity. And so that yellow around, that's this ioband tape, or basically this kind of antimicrobial kind of barrier as well. Now, this is an arthroscopic camera. So we make these small incisions. So there's one here and actually just one here. This blue structure, that's called a cannula, basically a tube that goes into the incision that then we can pass instruments through. The camera, what we're going to be looking at while we're operating, we're holding this handpiece and we are rotating the kind of the camera back and forth, but we're actually watching everything on a TV screen. So we get really good visualization. With this, we can kind of look around and move the camera, kind of look in different angles, versus doing it open. You just get basically one incision, but we can't, with an open incision, you think, oh, you could see better, but actually it's not the case, because you can't really kind of get around and see this. With these cameras, we can move them throughout the entire shoulder. So now this is the idea of what a rotator cuff repair would essentially look like. So, oops. On this screen here, this is more of an animated picture. If you have a rotator cuff tendon tear, we're going to repair it with sutures. There's different repair techniques. This is actually arthroscopic surgical photos that were taken. So when we do a surgery, not only are we watching the camera or watching the screen, but we can take kind of a snapshot picture so that we can document, but also show patients afterwards. This is what your rotator cuff tendon tear looked like. This is how we fixed it. This is what it looks like after we fixed it. So what we often do, this is your tendon here. This structure here, that's your humeral head. This is the footprint. So this is kind of confusing. So with this image, we're actually looking at the shoulder, basically straight on from the side, and then we're looking right at that tear. So we'll have to clean up this area called the footprint. We need to remove all the kind of old soft tissue or old rotator cuff tendon from this area, and then we call it preparing the rotator cuff bed. So we want to get a little bit of bleeding surface. So we use some arthroscopic instrumentation to roughen up the surface so it starts to bleed, because we need bleeding for healing. Then the way I fix these, which is not shown on this picture, but this is how the technique they did it here. You put a couple anchors in the bone. These anchors are real small. They can vary anywhere from 2.8 to just under 5 millimeters. So the anchors go into the bone, then they have suture attached, and there's different types of anchors and how many sutures are in each anchor, but essentially they're all the same. So you put the anchors in the bone, then the suture gets passed through the tendon to about here in multiple passes, and then we tie it down, and then these sutures get pulled all the way to the side and then get put into some other anchors on the side. So we're basically just passing the suture through the tendon and tying it down to seal that tendon back down to the bone. So then there's other work you can do at the time of an arthroscopic rotator cuff repair. We can address biceps pathology. There's some bone spurs we can clean up. There's a lot of other things we can do as well in conjunction with the rotator cuff repair. So after surgery, the postoperative course. So this is typical for my patients. I put them in a shoulder immobilizer for 6 weeks. So a shoulder immobilizer is a sling with a pillow between the sling and your abdomen. You're in that for 6 weeks. For 2.5 months, I don't want you to actively raise your arm, because with active motion, you're going to pull on that repair, and then that can potentially fail if you're pulling too much on that tendon. And it takes 3 months for the tendon to fully scar back down to bone. So we got to protect it for about 2.5 months. Now you're doing physical therapy 1 week after surgery. Even though you can't actively move your arm, they can passively move it. So active motion is you, the patient, actively ranging or bringing your arm up. Passive motion is either someone else is grabbing your arm and pulling it up, or you're using your other arm to move your arm. So there's a lot of things they can do even at a week after surgery to keep your motion as much as they can so it doesn't get too stiff. Then around 3 months, that's when you start building your strength back. After 3 months, full recovery, it really depends on the patient, depends on patient demands, kind of what activities they want to get back to. Anywhere from a month and a half to 3 months after that is pretty typical. So I'd say most patients by 6 months feel like, they're pretty much recovered. I got some patients that are really high demand that might be closer to 7-8 months before they're back doing everything. So that was just, it's pretty brief talk. Rotator cuff injuries there's a lot that goes into it, but hopefully that gave you guys some information about how we examine patients, what questions we ask in clinic, how often patients present, our workup, and then treatment options. So I'd be happy to take any questions. Lauren can maybe help facilitate that as well.
Yes, absolutely. We'll open up the floor to any questions that you guys have now. Anyone who has any questions, feel free to put it in the Q&A area, and then we'll address as many questions as possible. So it looks like we already have 2. So Dr. Eggert, whenever you're ready. Our first question is laser therapy offered, and what are your feelings on success or effective if it's a effective therapy?
Yeah, so here at OSMS, we do not offer laser therapy. Just like the biologic, there's a lot more research that's going into laser therapy, whether it's of the rotator cuff in the shoulder, knee arthritis, knee pain. Our Academy of Orthopedic Surgery actually has a recommendation for use of laser therapy on a lot of our orthopedic injuries. So we don't offer it here at OSMS. I know there's some good evidence to support it, especially even like in the postoperative course. So I'm not opposed to a lot of these other treatment options. If patients want to try it and it works, great. I just know that we don't offer it here, but there are some places around town that do.
Mm-hmm. Okay. If a person had an MRI a year ago, will another one be needed for your assessment?
That's a good question. So kind of depends. Depends on the patient, depends on the injury. It depends on what the MRI showed. If it's going to be something where I got an MRI on a patient and we try some non-operative things and gosh, it's been a year and now they're talking about, hey, my symptoms have gotten worse and we want to, we're thinking surgery. I typically get an updated MRI at least within a year, sometimes closer to 6 months, just so that I can give the patients kind of realistic expectations of what I'm going to see in surgery at the time of surgery. So we can talk about, have a more thorough and in-depth conversation about what we're going to be doing. So, but it does depend on the MRI if it's in the patient presentation. But if it's surgical discussions, I'd want an updated one.
Sure, sounds good. So this person says, can a torn bicep from 10 years ago be repaired?
Sure. Yeah, so I didn't talk about biceps injuries in this talk, but that's a good thing to talk about. So very commonly in the rotator, near the rotator cuff tendon, so there's actually a drawing here. This is the biceps tendon. There's two different biceps tendons. This is the long head, and this is the short head. The long head of the biceps tendon is inside the shoulder joint, and this is outside the shoulder joint. If you're talking about biceps tendon ruptures, often in the shoulder, we're talking about this one. That is one that at the time of surgery, depending on if you have some issues with the biceps tendon, we can cut it, let it go, or cut it, reattach it. If it's been torn for 10 years, unfortunately, that's not something you can repair. You often will just, because it's really scarred down, it's hard to find. So I've got some patients that we do this plan, or we kind of do it on, do it at the time of surgery. I've got other patients that have ruptured it. And you just they come in, their pain is often better, and you let it go, or you let it be. So short answer is no, at 10 years, you cannot go back and try to repair that.
Sure. And for someone who has torn their bicep tendon at that area close to the rotator cuff, could that potentially affect the rotator cuff at all?
No, generally not. If you have biceps pathology or biceps, your partial tear or tendonitis, once you release it and get off the tension, generally that pain should be gone. You kind of get some pain in the muscle, like muscle spasms. But no, once it's torn, that shouldn't address your rotator cuff. Now, all these structures are really close to each other. So even if your biceps was torn, sometimes you have a rotator cuff tear, and they're right next to each other. So it won't affect it, but it could just be that you might have a tear of your rotator cuff tendon in that area. That's
Thank
causing
you.
pain.
This person says, as an active 72-year-old female that kayaks, golfs, and swims, can you suggest any exercises that can strengthen a sore shoulder?
Yeah. Unfortunately, I don't have like a handout to give you guys over the webinar, but we have some good handouts in our clinic. I mean, they're not to say just you can Google a rotator cuff PT protocol. A lot of the PT exercises, it's going to be light weights. The rotator cuff muscles are really small. You don't need a lot of heavy weights. It's honestly 1, 2, maybe 3 pounds. A lot of shoulder abduction exercises using the weights and just kind of light bands. Looking up exercises on how to strengthen rotator cuff, I think, is reasonable. You can do it online. Just really focus on the light weights. As you get your arms out to the side, if you have anything heavy, that puts a lot of stress on the shoulder. If you are going to work on your bigger muscles, your deltoid, doing stuff overhead closer to your body is important. We do have some good exercises, a list of exercises here that we can always, if you want to, pop in, we can always get that. But no, I mean, not one specific exercise, like, besides some band work, lateral arm raises, forward arm raises. Those are all important. But the biggest thing is light weights, higher reps.
And you mentioned PT protocols, Dr. Eggert. I am going to, in the chat, put a link to some of the shoulder PT protocols that we have on our website. So if anyone wants to refer to that, since we don't have any handouts that we could give right now. Okay. What about reverse shoulder replacement? Is that something that you do? And sure, then if you have good range of motion but have lots of pains, what can be done for that?
Yeah, that's a good question. So yeah, so reverse shoulder replacement, and that's a big conversation as well, a big topic. So if you unfortunately have a rotator cuff tendon tear that's chronic, this has been completely torn for a while. What happens is the tendon pulls back, and it's the muscles are contracting, so they're pulling this tendon back, and then the ball here will start to rise up. So it's called superior migration, and so that's we see that with these chronic, we call it irreparable rotator cuff tendon tears. And so the option for that is a type of replacement. So with replacements, after you make an incision over the shoulder to get down to the shoulder joint, you're basically making a cut right across here. You're taking out the ball. We put typically a stem that goes down into the bone, into the center part of this bone, and then we put on this side, we usually where the cup is, we put a metal called base plate, a metal structure that's got multiple screws in here to keep it in there nice and solid. Then the reverse part is we put the ball on this side, on the cup side, and then the cup goes on the ball side. And that has to, the reason that they do that is because of the deficient or incompetent rotator cuff. Um, so that would seem more of a salvage technique, and it still is for it's kind of your last step for irreparable rotator cuff tendon tear. I do that procedure. A lot of my partners do that procedure as well. Motion, initially it was always thought as okay, that's their last option, especially if you have otherwise like a anatomic total shoulder replacement, which is the balls on this side and the cup is on this side. And if that fails, then you get a reverse. And people always thought, gosh, that's your motion's not going to be as good. Because of I think technique and also implant design that has changed. Patient's motion with reverses is still really pretty darn good. If you've got full range of motion, you can bring your arm all the way up before surgery. With the reverse, you could lose a little bit of that motion. It's going to be more for pain though, pain control doing a reverse.
Okay. And then what if you have bilateral shoulder pain? How would you approach that?
Yeah, that's pretty common that I see in my clinic. Still work it up, x-rays, sometimes MRI. I think, and also the MRI, I don't always need to jump right to that sometimes. And I didn't mention that, like, depending on the patient's symptoms, I often say, hey, these are our options. We could try some things first, or we could get, more imaging with an MRI than we know for sure. But I've gotten patients where we got MRIs on both shoulders. They come back, we run through it. And really depending on, oh no, I'm going to go run and grab my charger, Lauren.
Okay, no problem.
Let me grab that too. Let me just answer this question. I'll be right back. Really depending on patient symptoms, whichever one is worse, we might start there. We might say, let's inject one. And if, hey, you got a full thickness tear on this one, we're going to talk about surgery for that one. And then kind of get the other one we feel a bit better. Let me go grab that real quick, Lauren.
Okay, no problem. I see that there is a question about insurance and the type of insurance that you have and whether you need a referral to see Dr. Eggert and for an MRI. We personally do not require a referral in order to be seen by our physicians. Now, that being said, most insurances do not require a referral in order to be seen by an orthopedic physician or for pain management. However, we always say that it is good to double check with your insurance, whether you need a referral from them or not. So for this person who asked that question, I would recommend, and especially for an MRI, I would recommend just double checking just to be sure. All right, let me know whenever you're ready for your next question.
I think I'm ready. Looks like
okay.
It should be working.
If someone has osteoporosis, is that a risk for surgery at all?
Yeah, I mean, there's a concern sometimes with the anchors that they can. So we put the anchors into the bone, and if your bone is a bit weaker, they can pull out. Now, there's different techniques too. I've had patients that I've with osteoporosis with rotator cuff tendon tears that I've fixed, and they've done just fine. So that's just something that we need to think about preoperatively and kind of change maybe a little bit of the surgical plan using different implants.
Okay. Switching it up a little bit, someone is wondering what other joints you treat and then also what ages you treat.
Sure. So other joints would be hips, knees. So I do replacements of the shoulder, hips, and knees. I do arthroscopic work of the shoulders and knees. So around the knee, meniscus work, cartilage work. ACL reconstruction. I do fracture care as well, so that could be of the hand, kind of throughout the body, hand, ankle, knee. Um, Patient age range, I mean, anywhere from pediatrics to basically all ranges. Um, so
Yeah,
yeah,
wonderful. That was a great question. Then back to specifically with rotator cuffs, is there an age that you wouldn't do a rotator cuff repair on a full thickness repair? What determines if you decide against surgery for a full thickness tear?
yeah, there's a lot of it. I don't use age as my only cutoff, whether it's rotator cuff repair or other injuries or conditions. I think a lot has to do with patient activity and their overall health. I mean, if you're I don't know the exact age of the oldest patients I've fixed a rotator cuff tendon rupture on, but I don't use age as a cutoff. If you're active and you're healthy and the tendon tear is a little bit, still looks repairable, and there's things we look at on the MRI that we didn't talk about, the muscle quality. If there's a lot of atrophy, that's not a good sign. But if it looks good, depending on how long the symptoms have been present, um, otherwise patients are healthy and active. And I would, I definitely don't have a cutoff, an age cutoff.
Great. Now let's just say someone has a tear and they're not ready for surgery yet, and you decided that, they can continue on without surgery. What are some signs or indications that their tear may be getting worse and, surgery should probably happen?
Yeah, that's a good question. So typically your pain will get worse, or more frequent. Nighttime pain is a predictor that things are maybe getting worse, or just more frequent throughout the day. If it is getting worse, or if you have weakness, that's always a concern. Tears typically can get bigger in size. Our studies show, whether it's a partial tear or a small full thickness tear. Generally, on average, it's anywhere between 2 to 5 years. So it's not like, most soft tissue injuries, it's better to address it sooner, just because you get a better chance of repair, because or the blood supply can start to go down over time. But it's not like, oh my gosh, I need to get to it in a week or two. So you can definitely watch it. But if you notice, things are getting more painful, more frequent, nighttime pain, those are things you'd want to think about and get addressed then.
Yeah. And you mentioned, wanting to address this injury right away. Let's just say someone had this injury occur and, they might not have addressed it right away. They didn't think it was anything. And, after a few years, they're like, maybe this is something that I should get checked out. How does that change this process? Does it change it at all? Could it lead to any long-term risks?
Yeah, it depends. I mean, if you, I guess there's not a great answer. I mean, yes and no. If you have a full thickness tear that you're just kind of thinking, okay, either I know I have a tear, I got an MRI, and I'm just not going to treat it. Sometimes that goes on to irreparable, or you can't repair that tendon. And if you have continued pain and it's just not, wait too long, then unfortunately that option is I shouldn't say unfortunately, then your option is a reverse shoulder replacement, and we're not talking about doing the repair. Um, I mean, waiting on, if you have some tendonitis or a partial tear, yeah, it could get a little bigger. But again, I think most often we're going to still try the same treatment options: physical therapy, anti-inflammatories, injections. Those are all still on the table.
Um, is there anything you wish physical therapists and assistants would understand better in regards to treatment? So let's just say you send someone to physical therapy to try that as a conservative treatment. Is there anything that physical therapists should keep in mind?
Yeah, that's a tough one. I mean, in my practice, so I think knowing when treatment, okay, we're just not making progress anymore. I like physical therapy a lot. I think physical therapists are great. I've really gravitated towards a lot of therapists that I've had good success with, and I trust and kind of know what to look for. If, hey, we're just not going to make headway on this one. We need to either get an MRI, or maybe surgery is the option. I don't want patients to spend a lot of their time on PT if we just kind of know it's not going to work, and we've kind of reached a plateau and we're just not making any more progress. I don't want them to kind of either keep spending time, but also money. PT is expensive. I like it though, and I think they do a great job. But I want to make sure I work with therapists that know when to move on to plan B.
So then speaking of, you don't want them to plateau and physical therapy to no longer work. So is there a specific timeline, or how long do you find that if people are trying physical therapy for that, they should start considering something else if it isn't working?
Yeah, I think if you have, a good 6 to 8 weeks of good physical therapy, I think by that time, I mean, within 6 to 8 weeks, you should know. So it's pretty common for us to send a physical therapy referral and make an appointment for about 8 weeks, because it might take a week or two to get in to see the physical therapist. And then we get you back around 8 weeks and see how things are going.
Okay, great. If you need to get both shoulders done, what is the time span that you usually have between the surgeries?
Sure. So typically you want to wait I mean, I don't want you really to actively use that arm for about 2.5 months. You start building your strength around three. At 3 months, I'd probably be the soonest, but it probably closer to about 4 months apart. It's probably safe.
And then kind of speaking on that recovery time, when would you say that people can safely return to work, drive, return to activities like pickleball or other recreational activities?
Sure. So work, that can vary, kind of depends on people's job. If it's manual labor, I mean, I've got some patients that are probably out for good 4 months because if they have to lift heavy for 5 months. If it's desk work, as long as you're not moving this arm kind of too much and actually moving it, if you're doing kind of computer work, that's closer. If some patients want to get back around 6 weeks, 8 weeks, that's fine. Getting back playing pickleball. Depending on kind of how intense the pickleball is, could be anywhere probably 4 to 6 months.
What about driving?
Yeah, driving depends on the right or left arm. Technically, if you're in a shoulder immobilizer, I don't want you actively using it, at least for those first six weeks. I got most patients wait at least 6 weeks. Some people wait the whole 2.5 months before they're back driving. Some patients, it's hard to kind of hold them back, and they're probably driving closer to 8 weeks if it's their right arm, but just not really doing much with that right arm. But definitely for the first 6 weeks, recommend no driving.
It looks like we have one more question here. Does sleeping position impact shoulder pain or recovery?
Sleeping position can impact pain. So I've got a lot of patients that they say they can't lay on that side. It just hurts too much to lay directly on that side. So they might roll over on the other side. It wouldn't impact recovery. So when I do a rotator cuff repair and you're in that shoulder mobilizer, unfortunately, you're kind of in that all the time, even when you're sleeping. So most patients are going to be sleeping on their back. Sometimes they're sleeping in a lazy boy or recliner chair for a while, or they're sleeping with some pillows propped behind their arm just to support it.
Well, it looks like that is it for our questions. So just want to say thank you everyone for taking the time to join us tonight. Like I said before, one more question. How about,
Sure.
Looks like we had one last second question. I know you kind of touched on PRP before, but someone is wondering if you think PRP is good, if that is a good option to go with for conservative treatment to try.
Yeah, so PRP around the shoulder, there was some good evidence to begin with. So there's some studies that are maybe showing the PRP in the shoulder. It really isn't as promising as they thought. We do it for a lot of tendinopathies or like tendonitis, like around the patellar tendon or other areas. I think it's worth a try. PRP is very reasonable. I mean, some of the studies show it's not as good as we thought it was, though. Insurance often doesn't cover it. So it's definitely worth it. Like a lot of our things, I mean, even trying anti-inflammatory. I mean, we kind of throw a lot of different things at some of these problems. And I've got some patients that have done PRP and they had great success. And so um, sometimes insurance dictates a little bit what patients do. And if it's out of pocket cost, they might say, no, I'm not gonna proceed with PRP.
Understandable. Okay. Well, it looks like that is it for our questions. So once again, thank you everyone for joining. This webinar will be available on recording on our website. So feel free to go to our website to refer to this webinar at any point. Otherwise, if you guys have any further questions, feel free to schedule an appointment online. You can either schedule online at osmsgp.com, or you can schedule an appointment by giving our office a call at 920-430-8113. Thank you again and have a great rest of your night. Thank you, Dr. Eggert.
Yeah, thank you.